Good afternoon, everyone. It's a great pleasure to be here. It's a long time since I've spoken at the Psoriasis Association meeting, so I'm delighted to be here, and thank you, Nick, for that lovely introduction. Indeed, I am a dermatology nurse specialist. I work at Bedford Hospital currently in their phototherapy department, but I have a long and varied history in dermatology, so hopefully I'm going to be able to give you some back to basics. It was an interesting challenge to go back to thinking about, the fundamentals of, first of all, the big question is what is psoriasis? And I am going to ask that question, and we're going to have a little look at that. What do we mean by psoriasis? What does it look like? And then I will talk mainly about the more fundamental treatments, maybe the topical treatments, but I'm going to put them into the context of other treatments as well. So I will give you the full spectrum and the full picture of treatments that should be available to you, but we will focus on the topicals particularly. Okay, so what is psoriasis? I've got 4 images on the slide here, 4 different types of psoriasis, all of which look very different from each other. The first one here is the one that the vast majority of people who have psoriasis will experience, chronic plaque psoriasis. But these other 3 conditions are also called psoriasis. And I think there is probably an increased debate about how we label all these different conditions that look very different and whether we should be labeling them all psoriasis. Currently they are, but I think that may change in the future. So chronic plaque, which is about 80 to 90% of the people who have psoriasis will have that. This is pustular psoriasis, but it's on the sole of a foot, so plantar pustular psoriasis. This is a generalized pustular psoriasis, which fortunately is relatively uncommon. So that's where pustules appear across the body. And then this is an erythrodermic type of psoriasis. So this is basically where you don't see plaques anymore. It's just a generalized inflammation and erythema. And sometimes people will get these conditions without ever having experienced the kind of general plaque psoriasis. So what is psoriasis? Well, it looks very differently depending on what type you've got, and all these are still called psoriasis, although, as I say, I think that may, as we understand the pathophysiology of what's going on, that may change in the future. So if we look at some definitions around the place about what psoriasis is, and I sort of took a slightly historical context with this, which is good because we're celebrating 50 years of the Psoriasis Association, and I always remember that because I'm 50 this year as well, so me and the Psoriasis Association are the same age. But if you look at definitions for psoriasis across history, they have changed significantly. So originally, we would have probably thought about psoriasis as a sort of a description of what's happening on the skin surface. So it's a skin condition that causes red, flaky, crusty patches of skin covered with silvery scale. So that was, an early, very descriptive definition of what psoriasis is. It's saying what you see, if you like. Likewise, this one down here. We then started also thinking about psoriasis as a chronic recurring condition. So it's not a condition that we can cure. It's a condition that remits and relapses, so that it comes and goes, and often is something that is with people for long periods of their life, if not their entire life. So that's how we would generally describe a chronic condition. It's something that comes and goes and remits and relapses. I put this on just because that is sometimes how psoriasis is described. It makes me furious. Just a skin condition. And again, I think as we understand more and more about psoriasis, we understand all the other things that come with it. We know that it's associated with psychological issues. We know that it's associated with arthritis. But increasingly, we're understanding how it can be associated with other chronic conditions, and increasingly now we're understanding that it is, as we've already heard today, an immune condition. So psoriasis predominantly is an immune condition which shows its symptoms through the skin and through sometimes the joints. And I think it's really important. It's not just a scientific thing that's important about. I think it's important when people, politicians particularly, are trying to understand the impact that psoriasis has. If you can say this is an immune condition as opposed to just a skin condition, it makes people listen a little bit more. It makes people take a little bit more notice. And I quite like this one here on the left. Psoriasis actually starts underneath the skin. It's a chronic disease of the immune system that can range from mild to severe. So I quite like that sort of that first bit. Psoriasis actually starts underneath the skin. So this is, if you like, a definition. The cause of psoriasis is complex and driven primarily by an aberrant, that's an interesting word, immune response. So again, I put this picture in, and I don't expect us to go through it all at the moment, although we will look at it again, because I think it's useful. But when people say just a skin condition, this is what's happening under the skin in psoriasis. These are all the various immune responses that are going on, the various cells that are being triggered and stimulated. That's what's happening to turn normal skin into psoriatic skin. So we will come back to it in a tick, but you know, it isn't just a skin condition. There are other things going on. So just as a summary, there are some of these important factors. We have a genetic predisposition. There is often, but not always, but often an environmental trigger. We have this overactive, so there it is. I've used overactive rather than aberrant. I was quoting there, and I made a mistake because I quoted and didn't put who I'd quoted from. So that's a learning point for me. And then you have your symptoms of psoriasis, so your physical symptoms there. So erythema, or inflammation or redness, induration, which is thickening, and scaling. And those are obviously your three key symptoms, physical symptoms. And what I just want to focus on a little bit more now is this overactive immune system. And it's partly because I want, and I don't, maybe you do all have a very clear picture of why the biologic therapies work. I know it's taken me years to get my head around it, and largely I've only got my head around it because I've had to lecture to people about it, and that's always a good way of learning something, is if you have to teach somebody else. But this idea of an overactive immune system is quite a useful thing, I think, to get your head around. So if we look at your immune system, and we all have one, and generally they work beautifully for us. There's two bits to our immune system, the innate immune system and the adaptive immune system. Our innate immune system is that quick, immediate response that happens when we have an injury or an infection. And it usually involves white blood cells, otherwise known as leukocytes, and specifically an example is a macrophage. So your immune system is triggered by an infection or by an injury or whatever, and that's the immediate response. We also have a slower response, which is part of our adaptive immune system. So that slower response is more specific. It responds to specific allergens, so specific things that penetrate the skin, and involves these things that you will have heard an awful lot about if you've listened to lectures on biologics, called Tcells and cytokines. So cytokines are what I'm going to focus on because I like cytokines, and I've only really just learnt about what they really are. But as soon as I show you this slide, you will see some familiar terminology. So cytokines are basically just messengers. They carry messages around the place that trigger the way that cells respond, that trigger our immune system. And in psoriasis particularly, there are two of these messengers that you'll hear a lot of talk going on about. They're called specifically interleukins, and you'll have heard of IL-17 and IL-23. All IL stands for is interleukin. So you have these cytokines and these particular messengers. And these messengers are released by hyperactive, there you go, I've called them hyperactive this time, not overactive. So we've got hyperactive and overactive T cells, which release these messengers, and they tell other cells what to do. So, in psoriasis, basically, if you take it right back down to back to the basics of your immune system and what's happening within it, there are too many messages going around, which basically causes the inflammation that is experienced and the cell replication. So T cells normally trigger an immune response, which creates inflammation and cells to repair, cells to grow. But in psoriasis, that is hyperactive and going on too much. So I've been very crude and simplified it extremely, but that is the crux of it. You have got a cascade of events going on. So if we go back to our picture now, if you look at these little cells here, these are called keratinocytes, so they're basically the bottom layer of your epidermis, and they're called, if you can see there, they call it stressed, and they're stressed by the fact that you have a genetic predisposition and various different environmental stressors. And that then triggers this whole cascade of events which cause inflammation and cell over-replication. So let's look, I've given you a little brief immunological discussion. Let's look at a treatment timeline, because I think this is quite interesting when you look back in the history of the various different treatments for psoriasis. And back in the 1920s, we had coal tar, which won't surprise any of you that that's an ancient old treatment that's been used for a long, long time, but also UVB. And UVB has been used as a sort of a health benefit for many, many years. You know, as early as the 1920s, we've seen UVB being used. The 1950s saw the introductions of topical steroids, which obviously we make use of extensively nowadays. And also dithranol, another old favourite, which some of you will know of and some of you might not have experienced. 1960s saw methotrexate appear on the scene, and the 1970s saw PUVA. So that was when the combination of UVA and psoralen was brought in. 1980s saw systemic retinoids, so things like acitretin, and then the 1990s, and this was kind of the beginning of my career in dermatology, and I remember very clearly the vitamin D analogues coming out as, like, you know, those are the things like Dovanex, calcipotriol, calcitriol that came out then. That was the new, you know, that was the new world in terms of topical treatments for psoriasis. But we also have narrowband UVB, which is the very specific form of UVB that we know is much more effective than broadband UVB, which is the one that was used back then. So this is currently what is generally used. And then, of course, the 2000s, the noughties, has seen this enormous burgeoning of biologic therapies. So we've seen huge amounts of development there. But also, we have had some new topical therapies. So we've had the combined vitamin D and betamethasone, so your Dovabets, which I think has made topical treatments for psoriasis a lot better. And also off-license use of calcineurin inhibitors. So these are things like Protopic, tacrolimus, Elidel, and they're not licensed for use in psoriasis, but increasingly we're seeing them being used, particularly in areas of skin that are more delicate and on the face. So that's a sort of an 100-year kind of timeline, if you like, for the various different treatments that have happened for psoriasis. I haven't put the small molecule treatments, which we've heard about, on there, which are, again, another new development. And I think it's positive that we've seen there are increasingly more and more new developments going on, and hopefully that will continue. So let's, as promised, I said I was going to talk about sort of topical therapies for psoriasis. And as a nurse, I always have to start by talking about emollients. They are absolutely the fundamentals of most of the treatments that we do. Psoriasis, often people aren't told to use emollients in psoriasis. They don't have the sort of the importance that they do in other conditions like eczema, but I think that they can be hugely helpful from a fact of comfort, of reducing scaling, and generally making the skin feel less tight and itchy. I'm afraid that those aren't very clear because we've got too much light shining on the screen. This is my husband's knee. I have got his permission to show these pictures to you today. He has psoriasis, obviously. This isn't made up, this is true. And this is his knee before an emollient is applied, and this is his knee after an emollient is applied. I don't know if you can see it from where you are, but obviously here you have a lot of surface scale. And here, literally just after applying an emollient, there is much less surface scale because he's applied it and sort of rubbed it. when I talk to patients about using emollients, it's interesting. Often they say, actually, I don't like the way my skin looks after using an emollient, because to me that looks worse because it's redder and more obvious. But actually, it is very beneficial to use an emollient, and using an emollient with urea in it may be more helpful than using one without urea in it. Urea is what we call a humectant, so it helps to draw moisture into the skin and therefore rehydrate. It also can help get rid of some of that scale. So emollients, useful. If you can get your GP to prescribe them for you, well done you. You've achieved a great thing, because it's getting harder and harder to get GPs to prescribe them for you. So yes, applying an emollient, you should apply it in a downward direction, following the lie of the hair, and use plenty of it. I know that little amount isn't going to. You need to apply it extensively. So the kind of common treatments that people, topical treatments that people often use, coal tar, ditronol, and vitamin D. They all work. They don't work in exactly the same way, but they all work in similar ways, in that they alter the way that the skin cells develop. So we know that in psoriasis, skin cells are developing too quickly, and they're not maturing normally. So what all these things do is that they slow that process down, and they help to reduce induration. Acanthosis or psoriasiform hyperplasia are just two other words that you might use to describe that. But all three of these topical products are basically there to slow down the over-reproduction of skin cells. So this is just some tar treatments. So this is what the kind of the old-fashioned tar that might be used if you were having Ingram's regime, and then more modern sort of formulations of coal tar. Topical corticosteroids are increasingly, when I trained in dermatology, we didn't really use them at all, but they're increasingly seen as part of the treatment regime for psoriasis, either by themselves or in combination. And the reason why they are effective is that they take away that redness and erythema, so they make the skin look more normal. And then in combination with the vitamin D, they can tackle both the thickening and the overdevelopment of the skin cells, as well as the redness and the erythema. So I came in at the end of the discussion about Enstellar foam, which is there's a picture there. So all of these three are vitamin D analog with betamethasone or Dovabet. So they're all three of the same things, but what I'm just showing you is that they come in different formulations. So you may well have experienced these different formulations, whether it's a gel, an ointment, or a foam. And I think the end of the conversation that I heard earlier on is that generally there's a sense that the Enstellar gel is more effective, even though it's the same fundamental product. Its formulation means that it sinks into the skin better, that the skin receives it better, and therefore it's more effective. Topical calcineurin. So, as I mentioned at the beginning, this is a product, these are cream or ointment products that are not licensed for psoriasis. Calcineurin is an enzyme that enables T cells to do their job. So as we've already explored, in psoriasis you have T cells that are being hyperactive or overactive. And so if you can inhibit calcineurin, so if you can stop it from working, you can do two things. You can decrease the release of IL-2 from T cells, and you can decrease T cell proliferation. So basically what that's saying is that by stopping calcineurin from working, you can slow down that T cell activity, which we know is helpful with psoriasis. So this was originally designed as a treatment for eczema, but it's been found to be helpful in psoriasis, and as I've mentioned before, particularly in areas of psoriasis on delicate skin, so facial eczema, flexural eczema, places like that, it has been found to be quite helpful. So it's another part of the armamentarium that we have of treatments for psoriasis. So just as some kind of practical tips around your topical treatments, find an emollient that suits you, that you don't mind using. All topicals take a while to work. None of them happen quickly. And particularly the vitamin D analogues do take a while to show their benefit. So bear that in mind. Don't give up. Keep going with them. And psoriasis clears from the middle outwards. So just briefly, there are two different types of phototherapy. There's TL01, which is also known as narrowband UVB, and we are happy to deliver 500 treatments of TL01 UVB before really having any major concerns about increasing somebody's risk of skin cancer. So always the concern with phototherapy is that we're putting people at increased risk of skin cancer. But TL01, narrowband UVB, has been shown to be relatively safe in that regard. PUVA, we're a bit more concerned about, we're a bit more cautious. So PUVA is UVA in conjunction with a psoralen, so it's a tablet that you take or a bath that you immerse yourself in. And that's, we're more cautious, and we take caution after 200 treatments. So I mention that because phototherapy is very helpful, and although can be inconvenient, is a really excellent treatment for psoriasis, and can be used in conjunction with other oral medications and with topical medications. So this is a new kind of campaign. As Brian said, it's been funded by Novartis. But has anybody seen the advert on telly? Yeah. So, and I just think that's so, yeah. It's so positive that actually it's out there, people are talking about psoriasis. And it is a great website. As you quite rightly alluded to, it's a bit clunky, but if you want advice about questions to ask your doctor about how you can get clear skin, you know, this concept of clear skin, it's really, really useful. Lots of very good tips and hints on there. So I would recommend having a look at it. Thank you so much. Thank you for chipping in.